Continuity of care means the growing familiarity of a GP or a GP practice with a patient and often with a patient's family, something that can only develop over time, not something that starts when a patient's needs are already complex. Indeed, it is often the case that it is real continuity of care that leads to early diagnosis of health issues that will become complex over time if not identified early. Many GPs can give daily examples of this as patients pass through their surgery. We need to recognize that GPs develop their extensive skills by working with a wide range of patients with health problems ranging from the simple to the more complicated to the complex. A consequence of this is that GPs develop insights which allow them to recognize that a patient presenting with one condition may well have a number of other and perhaps more serious conditions requiring treatment. It is dangerous to limit GPs to a binary choice between seeing simple and complex patients. And from a patient perspective, it is the attendance at a home practice over a period of time which allows a patient and the family to develop the kind of trust which will make a successful treatment more probable.
I think there's been a huge amount of trust that's been broken from the last 2 months of what's come about. I think this committee would really like to see your engagement and consultation plan for the next year.
So where are those engagement plans and communication plans, please?
Can I also just add quickly, is this including a consultation? We're talking about co-production engagement.
So we don't see it as needing a formal consultation on the basis that this is trying to make happen at scale what's already happening in most practices. There will be a patient reference group at North West London level, and then in each primary care network, we'll be working with the PPGs there so they can develop proposals for their own area. And that's on the basis there is no blueprint at North West London level. It's for local implementation and decision.
Can I just clarify that? So you're saying because it's not a blanket one decision, and it's going to be focused locally on different areas on how they would adopt it. And that's why you're arguing it doesn't need consultation, because it's not a decision for 2 million.
Locally. Yeah.
Okay. I mean, because this has always come across as one decision for over 2 million people. That's why I think you can argue from our side why we would feel there would need to be a consultation.
No, so I can completely understand that that's what's come across. I don't think that's ever been the case. I think what's come out from North West London is a series of guidelines about how you might make happen at scale what already happens in each practice, but the delivery is local. So that's where those conversations would take place.
So what you are saying, again, that language is the issue, and it was based on your work with KPMG. And I think that's something for you to look at as well within the next year in the way that you work and who you work with and what will be effective, because you want to ensure that whatever you do over the next year is the way you come across is the way that you would like to come across, that things are clear. But from what I've heard today, especially from the speakers that we've had, it seems to be the proposal that's been the main issue beyond just the language in itself. With GP access, same-day access being such a big piece of work, probably one of the biggest transformational changes we would have seen over the last 75 years with the NHS, to make this happen in such a fast-paced way in itself, I think creates its own challenge and also creates its own bit of anxiety. What you've called for over the next year appears to be a tweak of what's already there. Should we be ensuring that this is starting from a complete base where GPs and patients are at the forefront of deciding what this looks like, and not anything that's been done already, to ensure that whatever is happening going forward is built, truly built and embedded by patients and by GPs and by the public, and not led by the IC, to ensure that that is what is needed, wanted. We've ensured that the health inequalities are looked at, that there are less barriers, that all the things that you say you want to achieve, and I think we want to collaboratively achieve, will happen in a way where patients truly are the center, where the GPs truly are the center up at this.
The complexities for us are national processes that determine certain principles and how these things get rolled out. At the other end, we've been determined to have a approach PCN by PCN and the co-production at that level. The kind of principles that are at stake here, which we've got to acknowledge, some of which are essentially embedded in national policy in response to the workforce crisis that we face in terms of the years ahead. So I think there's a balance to be struck in signalling that the various projects ahead, that there are things which are set in this and there are things which we can do now, and there are things in between those two things that are about that co-production over the year ahead. Some aspects of this are determined nationally. Some aspects of this are what we at North West London would need to potentially consult on, and there are some aspects which are, as Rory said, local.
Given the very large number of studies in recent years showing that those from poorer and or minority ethnic backgrounds get a notably poorer service from the NHS and others, why has the ICB not carried out a thorough impact assessment of the new system, which may well add additional barriers for these residents?
So that is part of the next stage. So when we start to look locally at what we're doing, because those proposals will differ in different areas, the proposals will be slightly different. So they would each have to have an EHIA attached to them locally. It's not something we can do at North West London level because we're not introducing a thing at North West London level on that's the same everywhere. So you'd have to look at each area for that.
I don't know if you want to come back, but let me just say, let me just understand a little bit more. So we heard Vijay say that there is going to be a degree of standardization across the geography, but then there is going to be pockets of individualities. And I just want to understand, how do we square that circle?
PCNs have ultimate flexibility. We would very much encourage them to be part of this program so that they're given the money and the resources that they can have to build a better access model for their patients going forward. We would be very, very hopeful that all of our practices and PCNs would be happy to join with us in a contract to make that money flow going forward.
But if they didn't want to, what would that?
Obviously, a contract is a contract. They can decide to opt in or opt out.
So it wouldn't jeopardize the.
I think that you know, I can't foresee what will be happening in April 25, I'm afraid. But you know, we'll be able to answer that question this time next year, is the answer. I'm not trying to be clever. I'm not trying to suggest that we will be doing one thing or another. I'm just saying I can't really answer that question.
I have concerns in terms of an independent evaluation. Why is there no published report and no published independent evaluation of the so-called pilot studies, as you would expect when a radical new system is being trialed? How can this be properly evaluated when they have been in operation, the pilot ones, for such a short period of time? There are many questions that we have. How did the pilot GP practices and clinicians ensure that their hubs care coordinators have the real clinical expertise? Another question for me is, what was the impact on patients of not being able to be seen by their own GP? Has this new system had any measurable impact on patient outcomes? So lots of questions.
We've learned from the conversations that we've had with these early adopters that they have found different ways of working which have been useful. And that is the knowledge that has come to be part of our proposals around what the 9 principles could look like.
Sorry to interrupt, but we did hear you say that, you know, how keen, how eager you are to have this co-design, co-produce, which are the buzzwords that we hear every day. Would it not have been helpful to have put that information out?
What we're doing is looking at those 10 early adopters, and we're saying what are the things that can be learned, that can be evaluated, and we will bring that to the public when that's available. These are anecdotal experiences from our early adopters, but once we've pulled that together, we're very happy to show that out to people.
I'm just concerned that this anecdotal sort of learning or experiences will then be used to inform a new process that will be then decided top down without proper and effective consultation. So that's an initial concern.
My experience tells me that trust is fragile, and you can see from the contributions from our speakers this morning that effectively it's broken. I think the ICB's approach to trying to implement this approach without proper engagement with patients and the public and healthcare professionals and in particular, this committee has been far from satisfactory. And I'm glad that you have apologised for this morning, Rob. I don't think that it is simply a question of the language that's been used. I think it is about the proposal that has been forthcoming. And I want to share some reflections from an Ealing resident, Martin Eady of Ealing Save Our NHS, specifically in terms of that proposal. He said to me, the main issue is the lack of continuity of care, and we've heard about that this morning. An illness requiring same-day care does not occur in a vacuum. The context is important. A GP will know the background of the patient, but an untrained stranger at a hub will not. Time taken to triage an urgent case will delay treatment, and the patient's GP will already know the circumstances. There is frankly confusion out there in our communities how we will ensure continuity of care and how, from a patient safety perspective, it will be safe and effective. I don't think I've had a response to my question. I asked very simply about how we would ensure continuity of care and how it would be safe and effective.
I'll give you an example. A patient may make contact with the practice. They may be picked up by a hub, a virtual hub. That patient's records will be available to the triager, the clinician, who is making that clinical decision about where their care is best led, and where they need continuity of care, they will be directed quite rightly back to their practice. Now, the way that clinicians work is not full-time. No GP works full-time within their practice. We probably would never be able to go back to Dr. Finley's casebook, to be honest with you, because we'll never be able to go back to a single GP looking after a whole community, not in Northwest London. So that's the balance that we're trying to articulate.
That is a mismatch with the current government's policy of having a named GP for every patient. And I think what you've effectively described there is putting in place barriers to accessing primary care, more gatekeepers to go through before you're actually seen by a doctor. And I've got a first-hand patient experience of this, who has shared with me that they were having problems with sciatica, that they got referred into this kind of triage system. They ended up with a pharmacy who then couldn't prescribe the medication that they needed, ended up back at a GP. Then they got bounced around to a first responder, I think they were called, or clinician, ended up then having to see the GP to get a referral to physiotherapist. People are being sent all over the shop. And what we're actually doing with proposals like this is fragmenting the system rather than looking at how we enhance outcomes for patients. I think that full implementation of the proposal is being delayed by one financial year. I think an equality impact assessment and a human rights impact assessment should be undertaken prior to any changes. So that would be one recommendation. As a committee, I think we should be seeking meaningful consultation with patients, the public and GPs. I would like to see feedback and evaluation provided from the pilots. And I would also like, in line with the question that I asked, I think this committee should be provided with how we're measuring patient safety and effectiveness in terms of these proposals.
Working as an individual practice, which is what we have been doing historically, is not really the way forward. For the average patient, as you all know, your first port of call is your GP surgery. That is not going to change. And we had no intention of diverting or deflecting individual care from the GP practice.
Our receptionists already do a degree of care navigation already. But what we can do is we can skill up our teams to be even better at that care navigation and have long ongoing conversations with the clinician who will be the overarching clinician, so that they can sense check.
What we describe as care navigators or care coordinators are in fact what your individual receptionists are doing day in, day out. When a patient rings up the surgery now, The receptionist makes some level of decision making, which you all understand and have experienced. What we're trying to say is that can we actually streamline that in a way that allows economies of scale to support the level of access that our patients require? So in terms of clinical decision making, that is always going to have to be made by a clinician.